Good morning, everybody. Happy Friday. Thanks for joining us for today's session of Changing the Way We Work, Community of Practice. I'm Eleanor Colledge. I'm a family physician. I work in East Toronto, and I'm also the CPD Program Director at the Department of Family and Community Medicine, the University of Toronto. Delighted that we can continue to bring you these sessions in partnership with the Ontario College of Family Physicians. And I'm going to turn things over now to our OCFP President, Dr. Jobin Varughese, to introduce the session. Jobin.
Thank you so much, and Happy New Year, everybody. Really looking forward. As we go to the next slide, I'll read the land acknowledgement. Oh, there you go. We acknowledge that the lands, no sound. We're just getting something saying no sound. I'm going to power through and see if the sound's working now. We acknowledge that the lands on which we are hosting this meeting includes the traditional territory of many nations. The OCFP and DFCM recognizes that many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve the health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Eleanor, I'll hand to you for a reflection.
Great, thanks. Next slide, please. So I'm calling in from Toronto, the lands traditionally used by the Anishinaabe, the Wendat, the Haudenosaunee, the Chippewas, and the Mississaugas of the Credit. And I wanted to, well, I was thinking about the fact that this community of practice is all about changing the way we work. And as you know, we really strive to provide you with like the knowledge, the tools, and resources to make actionable changes in your practice. And I was thinking about this with respect to reconciliation and how when issues are really big, it can be hard to know how to take action and how to make steps forward. At least I have sometimes found that to be the case. So I was actually really thrilled to find out about this book and obtain a copy. It's a book written by David Robertson. David Robertson lives in Winnipeg. He's a member of the Norway House Cree Nation. He's also, you actually may have heard of him before. He's written a lot of books, won a number of literary awards, books for youth and young adults, as well as a recent book on anxiety. Anyway, I really loved this book of his, which is called 52 Ways to Reconcile: How to Walk with Indigenous Peoples on the Path to Healing. And part of what I loved about it, it's very action oriented. It's 52 ways reflect the 52 weeks in the upcoming year, things that you can practically do over that year to walk on that path. So that part is wonderful about it. And then the other thing is I really was inspired by his attitude towards reconciliation as a community effort. And as he says here, reconciliation is a community effort. For it to work, it's all hands on deck. And he includes the fact that he's written this book to help those of us that are not Indigenous in terms of that path. And as he said, just remember, we're walking together every step of the way. That's how it needs to be done. So if you're looking for inspiration this year, maybe you have a New Year's resolution about taking action, highly recommend this book. Next slide, please. So just a reminder, our series is part of our sessions are part of a series, and you can always find these online. And we also always like to thank our scientific planning committee who help us to put together these sessions and ensure that they run smoothly. Next slide, please. If you did happen to miss today's session or you're watching this not live, just a reminder that you can gain credits by completing the self-learning program. There's a link at the bottom and you can click on that and submit it to get your Mainpro credits. Next slide. Great. I'm going to now turn things over to our panelists to introduce themselves. Thrilled to have Dr. Vaisman back. Turn it over to you for your conflicts of interest.
Hi, I'm Alon, Vaisman, infectious disease physician at UHM. I have no conflicts to report.
Thanks very much. And now over to Dr. Stephen Pomedli to introduce himself and his conflicts of interest.
Hi, everyone. I'm Dr. Steve Pomedli. I'm a family doctor in Toronto, and I receive funding from the Global Corporate Advisory Services team at Cleveland Clinic Canada. And I work with Ontario Health as an independent contractor, and I'm also a clinical advisory board member with Layla Care.
Thanks very much, Steve. Next slide, over to you, Jobin.
Thanks so much. And hi, everybody. I'm Jobin Varughese. I'm the president of the Terra College of Family Physicians, where I do receive a stipend, as well as I'm assistant dean of primary care education at the TMU School of Medicine. Thank you.
Thanks, Jobin. I've already introduced myself. My conflicts of interest, well, I don't believe they pose any conflict, but I do receive an honoraria from the OCFP, as well as from the Foundation for Medical Practice Education, and I am on salary at the Department of Family and Community Medicine. Okay, next slide, please. So just a reminder as we enter the new year on how to participate. If you happen to be new to our community practice, welcome. Please post your questions in the Q&A. And if you see a question that's there that you'd like answered, please upvote it rather than writing it again, because then I know to prioritize those questions. And then, of course, please use our chat to say hello, Happy New Year, and also to share your resources, tools, your thoughts. Anything you want to do in terms of networking, please pop that in the chat. Next slide, please. Great. So just to let you know how the morning's going to run, we're going to start with Dr. Vaisman, who's going to bring us up to date on what's happening in this very wintry winter. And then we'll break for questions, and then we'll turn things over to Dr. Pomedli to hear about e-referral and some things that are coming down the pipeline from that perspective. And we'll break for questions after that. We'll be finished all our main content by 9 a.m. If we need to extend for some additional questions, we'll come back until about 9:15. Great. I will turn things over to Dr. Vaisman to get us started. Thank you.
Thank you. Good morning. Thanks for having me. As I mentioned before, I'm Alon, an infectious disease and infection control physician at UHN. Next slide. So the objective of today's talk is to give you an update on the current activity of viral respiratory infections in Ontario. We'll talk about a few other things at the end as well. All right, so I think everyone is very well aware that influenza has had a significant amount of cases this year. So on the next slide, we'll talk about why that is. I think a lot of people are recognizing that when the influenza vaccine was brought out this season, we knew that unfortunately there was a mismatch associated with it. So this new subclade of H3N2, which developed in the Southern Hemisphere late in the influenza season down there, unfortunately is what's resulted in a lot of spread then in the Southern Hemisphere and now in the Northern Hemisphere. And the specific mutation that resulted in this new subclade actually confers evasion of the immune system. And because it's a new virus strain, it also evades the vaccine that we have. Not completely, but it's because of that mismatch that we're seeing a lot of cases. So on the next slide, you'll see the trend that's been going on the last few weeks. And what was a little bit unusual this year is that the peak of influenza actually occurred a little bit early. So it occurred in about the middle or third week of December, where it typically occurs in the first week of January. In the last few years, post-pandemic, we've actually seen the flu peaks occur at different times. So in that sense, it's not unusual. But if we compare it to pre-pandemic setting, it's a little bit unusual that the peak already occurred. So the number of cases has peaked. Also, the percent positivity of cases and testing across the province has also peaked. This is also reflected in the US, and it's also reflected across Canada. So it seems as though the worst of flu has already passed around 2 to 3 weeks ago. Next slide. So the big question I think a lot of general practitioners would have is, how do I use Tamiflu or oseltamivir for treatment of influenza? So just a few things to keep in mind about this drug, Tamiflu. First of all, resistance is rare to the most common strains that we're dealing with. So H1N1 and then the H3N2 subclade, there is no resistance to that one actually. And with H1N1, it's quite rare. Second of all, it's very rare to have contraindications to the use of the drug. It's safe to use in pregnancy. It's safe to use for those who are breastfeeding. And it's also generally easy to work around the drug interactions associated with it. And also it's important to counsel your patients. Around 5 to 10% of the time, they're going to experience nausea and vomiting. Next slide. So how do I know whether somebody has flu? It's important to recognize that unlike the days of COVID where we had rapid testing, with flu, we don't have that. And before the pandemic, as you all know, we didn't really even do any kind of testing for viral respiratory infections whatsoever in the outpatient setting. It was all primarily focused on the inpatient setting. So the important thing is to recognize people who have an influenza-like illness. Those are the people who you will start potentially treating with Tamiflu if they qualify. So an influenza-like illness is a definition that's used across the board, WHO, CDC, PHAC. Essentially what it is somebody who has fever and cough, plus 2 of the 4 of sore throat, arthralgia, myalgia, and prostration. Prostration is a rare medical condition where your prostrate has to violently escape from your body. All right, next slide. What is the principle around treatment of non-severe influenza? So you will also see people with influenza-like illness in your clinic, how you decide whether to treat them or not. First thing to understand, as I mentioned, there is no confirmatory testing that's necessary. You may have access to testing in an inpatient setting, but almost certainly you will not. So you have to use the definition, the ILI, to decide who gets treatment. Second of all, use local influenza data to figure out whether there's a lot of influenza circulating. So the Public Health Ontario website is very helpful. Also, each of your public health units will report this data as well. There is no threshold that we're aware of that, dictates whether you should treat, whether it's 5%, 10% positivity. You just have to use your judgment to figure that out. And also, we generally want to aim to treat patients within 48 hours of initiation of their symptoms. If you're beyond 48 hours, you have to use your discretion based on the risk, whether to start treatment or not. Next slide. So in non-severe influenza, basically anyone who's greater than 5 years old, so including those children plus all the adults, would be treated if they have risk factors. And I'll mention what those risk factors are later. That's all defined by the Public Health Ontario or the Ontario Health document. So essentially all those people should be treated with Tamiflu if they have risk factors. In less than 1-year-olds, it's very tricky. We don't have the outpatient antivirals to treat them readily, so you'd have to consult ID or send them to a clinic, send them to an ER to get treated if you're concerned. For those who are 1 to 5, you could initiate treatment for those kids, regardless if they have risk factors or not. Next slide. So for severe influenza, essentially the difference there is that even for anyone above the age of 5, you would treat them regardless whether they have symptoms. Severe influenza, I'll show you on the next few slides what that defines, but you could probably tell what that is. Essentially, it means that patients who have not just the ILI illness, but also have symptoms of severity like difficulty breathing or lethargy or deoxygenation, for example. And of course, if you have severe influenza and you're less than 1 year old, you should probably go to a hospital for assessment. And then also, if you have severe influenza, you have contraindications to treatment, you should consult ID or consider just referring them to hospital. I think for the most part, anyone who does outpatient medicine sees a patient of severe influenza, regardless of their age, will probably decide to send them to hospital because, again, it's hard to predict in some of those populations, especially with the risk factors, which way they're going to trend. Next slide. So this is the definition of what risk factors are for influenza. And there's a whole host of them. And of course, I think they all are pretty intuitive. Patients who are elderly, patients who are immunocompromised, who have comorbidities like diabetes, cystic fibrosis, cancer, neurological conditions, and then a whole bunch of other groups as well that are potentially at higher risk of developing complications from flu, such as the indigenous population or people with morbid obesity, for example. Next slide. And then this also, again, just for your reference, what is the definition of somebody who has severity? What is the severity definition for influenza? It's those people who have people who have severe illness or those who have complications associated with it, such as neurological symptoms, shortness of breath, any sign of shock. And those who do not are considered to have non-severe. Next slide. And again, this is just for your reference for the slides. So you have them is the definition of, or the approach to treating patients who are children with influenza. On the next slide, you'll see the same approach for people who are adults. This is just for your reference. You can go through them. If you just Google Ontario Health Influenza algorithm, you will see this approach in there. It's pretty straightforward, but essentially I've summarized it all. Next slide. So what about other infections? So we spoke about flu. What has been going on with other infections across the province during this winter season? Next slide. So just to quickly summarize what's going on recently, we saw a large measles outbreak occur in Ontario and across other parts of Canada in the early part of 2025. So that was predominantly January, February, March, April, May. And then cases started to taper off after that. The peak was roughly in March or April of last year. So it's conceivable that we're going to see that again this year, where there may be other measles activity again. So we kind of haven't thought about it for a while, especially the latter half of 2025. So maybe time to start thinking about measles again, about the signs and symptoms and how we're going to test for it as well. The COVID cases have been remaining stable for a very long time now. If you look at our inpatient numbers at most hospitals in Ontario, you'll see that a very, very small proportion of patients have COVID or admitted with COVID, even during the respiratory viral season. The people who are admitted with respiratory viruses are almost all influenza, with a small number of RSV. And RSV cases, if you look at the PHO numbers, are actually slowly rising. So based on PHO numbers, we anticipate there's going to be a peak of RSV later this month or early in February. Fortunately, RSV is associated with slightly less morbidity mortality, but also it's associated with generally fewer cases than flu. So we're not anticipating it's going to have the same impact on healthcare as the flu peak had back in December. And then the last one that we often talk about is invasive group A strep, and there hasn't been a surge of cases lately from group A strep. It just basically currently seems to be the baseline numbers. And then one last thing just to say on the next slide about avian influenza. So just to remind everyone what we're talking about here, we have different types of influenza on the left. In the middle, you see the different strains of swine flu and avian flu. And remember that when we talk about avian influenza, the ones that we're concerned about causing high morbidity mortality, we're talking about high pathogenicity strains of avian flu. So these are substrains of the avian flu strains. So in terms of what's going on there, we have seen cases in Canada associated with animals, and a rare case in BC was associated with actually a person acquired the disease. In the US, the cases that were acquired from animals recently, a summary report was published in the New England Journal that showed the morbidity was actually relatively lower than other cases of avian influenza that we're seeing around the world prior to that. So overall, there hasn't been a significant change over the last 12 months in avian influenza. There's still ongoing surveillance occurring at Public Health Ontario. All the hospitals are sending some of their strains to the Public Health Ontario for typing as well. So not much on that front currently. Next slide. So to summarize, there was a significant rise in influenza cases associated with the new H3N2 subclade that arose from the Southern Hemisphere. Keep in mind that Tamiflu can be given to those patients who are suspected to have flu with meeting the definition of ILI. Even if you don't have any testing for it, it's based on a suspicion and perhaps also risk factors as well. Well, definitely based on risk factors, but perhaps based on exposure risk factors, I mean. And then other respiratory viruses, we haven't seen a significant rise quite yet. RSV would be the one that we're most concerned about next. And just to say also similarly with flu, RSV, we don't do outpatient testing for it. And we don't actually have therapeutics for it as an outpatient. So generally the approach for RSV would be supportive. All right, thank you, everyone.
Great. Thanks very much for bringing us up to date, Alon. And I'm not sure if everybody was awake for your definition of prostration, but I'm pretty sure that wasn't quite right. But I haven't heard that word for a long time. Anyway, turning it over, I think actually the questions that have come up really to the top here are around the rapid tests that are available. So a couple questions. So rapid tests for flu A and B are available. Are they accurate enough to use? Should we be consider using them? Yeah, so would appreciate your thoughts on the rapid tests that are out there.
Yeah, so it's definitely hard to acquire them, and they also have associated with costs. So the other thing to keep in mind with flu, similar to COVID, if you recall for COVID, we had a 5-day window to treat patients with antivirals in the early phase of their illness. Flu, it's even shorter, it's 48. So if you have a patient, often they will not present to you in the very first moment of their illness. They may present to you a day or two after their illness began. You want to be able to treat them immediately. So if you have to acquire a rapid test or the patient does, that delays treatment. The test characteristics are not as well defined also as we have for COVID for this strain. Presumably it's probably the same, but I would say that given the prevalence of flu, given the likelihood the patient has flu, especially in January, because cases are still high, the approach should include, as based on the Public Health Ontario recommendations, just to treat empirically. You don't need to have a confirmatory test. Unlike COVID, where it was easy to test, just go ahead and treat if they meet the definition of ILI, and especially if they have risk factors.
Great. So you're not recommending, I guess what somebody had written is that you can purchase rapid flu and COVID tests from PPE Supply Canada and use those. You're recommending that really just take a symptom-based approach.
Exactly. A symptom and a history, especially if the patient, if you're working at an LTC or retirement home where there's been an outbreak or there's an exposure in the household to somebody who has an ILI as well, that raises the probability of flu, and therefore you wouldn't need to do the testing.
Great. A quick question around testing. Someone was wondering, and not sure if you know about this, in long-term care, do they usually test first, or is it again just based on symptoms?
Yeah, it's an interesting question. The long-term care facilities across the province have different access to testing. Some of them have access to testing in the hospitals. Some of them use Public Health Ontario. Some of them are using antigen testing actually rather than confirmatory PCR testing. So it is quite variable depending on which LTC you work in. Also, the turnaround time for some of them are quite long. So depending on where you are in the GTA or other sites across Ontario, it might take a while. And sometimes, as you know, outbreaks are declared in LTCs not based on confirmatory PCR testing, but based on case definition. So it all depends on what setting you're working in.
Great, thanks very much. Now, a couple of questions around treatment. So I think really just to clarify, are you suggesting that since all people over 65 are high risk for flu, if we see them within 48 hours and they're presenting with the classic symptoms, we should go ahead and treat them? We shouldn't be waiting for a test.
Exactly. Exactly. The only exception would be if they have contraindications, which would be, generally speaking, contraindications are just severe adverse reactions to the drug in the past.
Excellent. And I know you spoke about how it's best to treat within the 48-hour window. I guess there's a question here at what point would you stop, or I guess at what point will it provide no effect? So at how many days would you still consider prescribing it beyond that 48 hours?
Yeah, very good question. I think somewhere be at the 4 or 5 day mark is where the impact is probably fairly low. And the reason that the viral load in the patient has fallen significantly by that time. So just like COVID, the viral level in a patient after they acquire the infection is quite high in the beginning, hence why antivirals are very effective. It's just that with flu, that peak is much shorter than with COVID, where you have that 5 day window. So yeah, probably beyond 4 or 5 days, the efficacy is probably pretty minimal. On the other hand, keep in mind that unlike with COVID medications, Tamiflu is far less intolerance, and the drug interactions are far fewer as well. We give it out, I know it's kind of funny, but we give it almost like candy in the hospital when we have outbreaks, especially in LTCs. It's just that the morbidity associated with flu is so high and the side effects with Tamiflu is so low that the risk-benefit ratio often favors just giving it if you have any kind of sense the patient has risk. Furthermore, as I mentioned, the Tamiflu resistance is so low in Canada that it's very unlikely, very rare to develop resistance as a result of using the drug, unlike antimicrobials that we see like antibiotics or antifungals. So that's why it's very often given even after beyond the 48-hour window.
Great, thanks for clarifying that, and good to know that we can prescribe it liberally and not be concerned as much about side effects. In terms of the dosing, a question here about patients that have a creatinine clearance in the 30 to 60 range. Alon writes that I thought it was the 30 milligram dose, but it's hard to find that dosage due to shortages.
Yes, that's correct. So if the creatinine clearance exists, you have to adjust the dose. And if it's very severe, very low, then yes, the dose becomes much lower. And that's a good question. I'm sorry, I don't know how I'm not sure about how the availability works in the pharmacies for the lower doses. I'm not sure. I mean, the hospitals would certainly have it in their pharmacies. So I suppose that's one solution is to speak to the outpatient pharmacies at the tertiary sites. But I'm not sure, or any hospital, I should say, actually. But beyond that, I'm not sure what the availability issues.
Great. And before we jump away from influenza, actually, I have a question for Dan Warshawski, who's joined us here. Thanks, Dan. Just a question here that rapid testing for influenza A and B and COVID-19 is available. Many commercial kits are available. And I guess there's a question here about why it's not offered in primary care. I don't know if you could speak to that at all.
Sure, and it's a great question. And I think, first, hi, everybody. Sorry. I think what we can say is, so we're all very used to COVID rapid antigen testing in the primary care setting at this point. Particularly the specificity of that test is very, very good, even if it's not that sensitive. So I know Eleanor was already speaking about like how we miss a lot with a COVID rat in terms of positives, but if it's positive, we're really sure it's positive for COVID. The flu rapid antigen tests are not quite as good and not quite as specific. So even though they'll still miss probably more flus than a COVID would miss for the COVID antigen tests, but a positive, we're not quite as confident in the positives either. So it makes it really difficult to be something that we want to, present as a really good option to help with Tamiflu use. I think what I'll say is there's a lot of discussion about this right now, and some of it depends on who you talk to, right? People are like, well, we're used to COVID. Why don't we just use the flu ones now too? And if you talk to some of the, more in-depth lab microbiologists, they'll say, absolutely not. This is not an appropriate test to use in these sorts of settings. So I think more to come, but the fact is we already knew the COVID rapid antigen tests were not great tests. The flu ones are worse, which is why it's not heavily promoted to be using the primary care setting. And to Alon's point from before, the risks from Tamiflu are so low, right? Like you can just, if you have a concern, you can just give it in a way that for Paxlovid and the COVID therapeutics, we didn't have that same level of being comfortable with just giving it in the same way.
Great. Thanks for outlining some of the challenges with that test, Dan, and answering that question. So I'll maybe keep you both on for this question because I'm not sure who's going to answer it or best. This is regarding Paxlovid. I'll read the question out loud. Our hospital recently sent out a memo that states remdesivir and Paxlovid remain stocked. However, these medications are no longer publicly funded. This came with a treatment algorithm that showed treatment is still recommended. And this came about after a 93-year-old inpatient with COVID caught in our hospital outbreak was not given Paxlovid because it was not covered. So I guess it's around who's covered and who's not regarding Paxlovid.
I can take the coverage question, Alon, if that's okay. So Paxlovid and remdesivir. So Paxlovid is not like universally covered anymore like it was during pandemic times. It is still covered for anybody on Ontario drug benefit, which includes everybody over 65. So I don't understand how it wouldn't be funded in a hospital setting. Additionally, like hospital drugs for use are also funded differently than that. So if we're talking the outpatient setting, any patient over 65 is still covered through Ontario drug benefit. Obviously Ontario Health has the guidance on what the recommendations are for who should be getting it, and it has narrowed and narrowed over the years and what we see, but it's still widely available if you have ODB coverage. In the hospital setting, the funding is totally different. In hospital, your drug should be covered. So I don't totally understand how that situation would have arisen that they wouldn't be able to get Paxlovid. It's available if needed. Remdesivir, I believe, is still kind of a little more broadly funded, even beyond ODB. It's extremely rarely used in these cases, usually these days. But you can have, because it's IV administration, you can get it kind of organized through your OH region, and there's coverage available.
Great. Thanks for clarifying, Dan. Another question regarding Tamiflu, Alon. Is Tamiflu used to prevent complications or does it help with symptom resolution?
Yeah, the main reason we use it in the outpatient is to prevent them from having bad outcomes associated with influenza. So the viral load will drop as it is, but we want to prevent them from being hospitalized and have morbidity, mortality. So that's why we would use it in high-risk patients in the outpatient setting.
Thanks, Alon. And a question, I'm actually not familiar with this drug. Is Zoxfluza available in Canada? Only one dose required and you're done and no nausea, writes Esther.
What is the trade name, the generic name for that one?
I'm not sure.
It's Baloxavir.
Oh, Baloxavir, yeah.
Okay.
Baloxavir is commented on in the document from AOH, but it's not favored over Tamiflu because of potential resistance as well. So Tamiflu is the recommended agent as first line for patients in Ontario.
Great. Thanks very much. And a question regarding RSV. So NACI prefers Beyfortus and the SOGC recommends Abrysvo. What should we recommend to the average risk patient?
Yeah, I think the NACI guidelines, we would follow the NACI guidelines in terms of the recommended RSV vaccine. And certainly that's what's available in Ontario for administration.
Yeah, and just to add, so Abrysvo is also available and publicly funded if people want it. It is considered second line following NACI. That's a slightly different reading of SOGC than the last one I looked, so I might have to double check it because I thought they were presenting them essentially at an equivalence level, as opposed to preferring maternal or parental immunization. But happy to follow up on that as well. But within Ontario, nirsevimab is still the preferred product, although Abrysvo is available specifically if a parent isn't going to want nirsevimab, or there may be difficulties with receiving it afterwards.
Great. Thanks very much, both of you. So A question regarding pediatrics. For kids less than age 5, it's challenging to ask about myalgia or arthralgia. Any suggestions? And I know, Alon, you might not deal with pediatrics as much, but any suggestions about how you would ask around those questions in the pediatric population?
Yeah, I see how that could be challenging. I think other things to ask the parents is about activity of the child, whether they remain active as they would normally, doing things during the day, their daily activities, their social stuff like sports or things like that. That may be a way to address whether they have any muscle pain or you know, arthralgias. Again, if you have, especially in a child who has any kind of concern of having complication, then you may want to err on the side of caution if you're not able to obtain a full history for the child. So if you know their medical history is of any concern, you would just go ahead, especially if they meet close to the definition of an ILI.
Great. And I'm going to finish off with two questions around vaccines just before we turn things over to our second speaker. So first, regarding flu shots, is it still useful to give flu shots to patients that want them now, or is it not necessary now that the peak is done?
Yeah, this is a important thing to address with patients that there's never a time where you should not get a flu vaccine. If a flu vaccine is available and you have not gotten it during this season, so you don't need to get it twice in a season, but if you have not gotten it during the season, you should get it regardless of when we are. We would prefer you have gotten it in the beginning to right before the peak would have occurred, so or mid-October is when it would have been available. But at any time, you should get vaccinated. One, because you could still be protected from cases that are still around and the positivity rate is still high. The second thing is that flu vaccine also confers benefit for future years. So if you haven't been vaccinated years before, it's even more reason to get it now. So at any time, if a flu vaccine is offered to you, you should get it during the winter season, up until, whenever it's taken away, usually March, April.
Great. And then the second question actually is regarding the COVID vaccine. So is there a stop for the COVID vaccine? Had patients who got 10 so far, they keep going and change between the Pfizer and Moderna.
Unfortunately, the data now supporting COVID vaccination is far poor. The quality of that data is far poorer than it was in past. So we had large scale randomized controlled trials 5 years ago with 50,000 people in each arm. Now, if you look at the NACI statement and look at their citations, there's no RCTs. It's a lot of observational data and not well controlled as it used to be because there's a lot of confounding now with people having recurrent infections and numerous courses of vaccination. So the NACI statement is basically just says 6 months, every 6 months for patients who are at high risk. And there's a statement with should, and then the rest of the population is may. So may would be basically everyone else who doesn't have risk factors. It's very unclear now how much benefit people are getting. Probably is quite minimal given how much circulation there is. On the other hand, the risks associated with Pfizer and Moderna is very, very, very low. So you might say to yourself, well, why not just get vaccinated if the risk is extremely low and there's even a small benefit? And because we don't have as good numbers with testing, we don't know, how much of it is circulating in the general population as an outpatient anymore. So, and it doesn't really make a difference whether it's Pfizer or Moderna to that question. Either one would be acceptable.
Great. Thanks very much. Thanks for your talk, Alon, and thanks for jumping on for the questions as well, Dan. There are a few remaining questions in the chat. If you guys have the opportunity to take a peek at them, that would be great. Otherwise, I'm going to turn things over now to Dr. Pomedli to really a change of gears here towards referrals, something that we deal with every day.
Awesome. Thanks, Eleanor, and happy to be here today and appreciate the opportunity to talk about what we've been up to at Ontario Health through the Patients Before Paperwork program. So as mentioned earlier, I'm Steve Pomedli. I'm a family doctor in Toronto and the provincial clinical lead for e-Referral at Ontario Health. If we can just flip to the next slide. So the P4P program is centered around the quintuple aim and has the goals to increase the adoption and utilization of digital products and to reduce fax volume, reduce administrative burden, and improve provider satisfaction overall with digital tools. And via these levers also to enhance the overall patient experience and quality of care. So the P4P program is several years in the making and has embedded clinical leads at the core of the program, including 5 family doctors and 2 specialists from across Ontario. And this is critical as this kind of recognizes the importance of having individuals with clinical experience as part of the leadership, development, and rollout of the initiatives under the P4P umbrella. And while I think the mission and these goals resonate with most of us in primary care, we do recognize that there can be indeed some inherent trade-offs here between the goals of, reducing fax volume, adopting digital tools, and reducing administrative burden. And part of our role as clinical leads is to guide this program in a direction that best supports the work we do as clinicians and contributes to a better functioning system overall. So if we can just pop to the next slide. There are a range of products and services that we are guiding the development of, including e-prescription solutions, e-ordering products for lab test orders, health report manager or HRM modernization, and the digitization and streamlining of forms that are submitted to other ministries, such as the Ministry of Transportation forms. So today I'll be focusing primarily on e-Referral on the left there, as there has been significant work over the last 18 months or so to bolster the underlying e-Referral infrastructure and to best support clinicians across the province. If we can just slide to the next slide. As many of you know, there has been an onboarding pause for providers coming onto e-Referral due to an ongoing procurement process to select a primary referral management system for the provincial e-Referral network going forward. As of late last year, the pause has been lifted with onboarding now resumed. So feel free to share that with your colleagues, but with Ocean MD selected as the primary referral management system across the province. In addition, the government is committed to long-term funding for the program to ensure that this system is fully funded with no cost to sending or receiving clinicians or hospitals. And what this slide illustrates is that coming out of the procurement process, we now have a new underlying provincial e-referral architecture. And while this new plumbing will mostly be invisible to clinician users, the takeaway here is that we now have the infrastructure in place to scale and support e-referral across the province. And with the introduction of the Provincial Care Coordination Gateway at the middle, as you can see here, this supports scalable integrations across the province with various types of senders and receivers, including hospitals in particular. It also allows for collating the e-referral data that flows through the system at an aggregate level. So this helps us better understand wait times, challenges related to uneven bottlenecks, access, and things like that. And it introduces new opportunities for health system stewardship and ways to improve the referral system as a whole. Next slide. And fortunately, this new architecture builds directly from the existing e-referral network that many of us have already been using. And there's been, as of last year, for the fiscal year 24-25, there were 1.3 million e-referrals sent in Ontario last year. And when you look across regions, over 50% of family docs and NPs are using e-referral to some extent in their practices. And I think, we have such solid initial clinical uptake because in primary care, we recognize the key value that an e-referral system brings. So for clinicians, for clinics and staff, and for patients, with e-referrals being trackable end-to-end, reductions in lost referrals, and patients being updated along the way. However, we have work to do in getting specialists and receiving clinics on board, as we're sitting at around 10% of receiving specialists currently on e-referral. Now, this varies by region, so some regions have much stronger uptake and some regions are just getting off the ground, but this is a big focus of the work we are doing in 2026. Next slide. So given this need for a more robust network of receiving sites and specialists, a key focus for Ontario Health and hospitals in 2026 will be getting a large number of specialists and receiving clinics listed and actively receiving e-referrals. We are supporting a number of major hospitals across regions, namely the ones listed here, to come on board throughout the course of 2026. And this is supported by several forthcoming integrations between the e-referral network and their hospital information systems, which supports that full end-to-end digitized referral process. Next slide. Another key part of the new e-referral network will be the emergence of standardized referral forms for many different types of referral pathways. And these are intended to gradually replace the over 1,300 different formats of e-referral forms that have accrued across receiving sites in the current e-referral network. These new standardized referral forms, which will soon be available for the majority of referral types in Ontario, they've been rigorously co-designed with primary care providers and specialists across the province, with the intention of creating a more efficient and more streamlined referral process for senders and receivers. The new forms accomplish this by ensuring that e-referral forms across receiving sites have a similar and familiar feel. They're reasonably quick to complete and meet the needs of the receiving site or specialist. Part of this includes having standardized but configurable ways for receiving sites to remove from the form what they do not see in their clinical practice, which makes it much easier to ensure you as the sending provider are sending the right referral to the right destination, which reduces the rate of declined referrals or bounce backs. If we just go to the next slide. So this slide just highlights how these forms are developed by the team at Ontario Health, led by Dr. Erin Keeley. They go through a rigorous process with significant physician input to ensure that each of the new standardized referral forms meets the needs of senders and receivers alike. And there's also a plan to have iteration. So we'll learn a lot with initial deployment of these forms with intention to continue to improve them based on user feedback. And if you get emails through the OMA this week, you will have seen a call for input on the latest round of standardized referral forms. So be sure to take a look and share your feedback. Next slide. So 2026 is a great time to get started with e-referral if you aren't already involved. And just to hit on those kind of key points, so e-referral is now backed by long-term funding commitment, and the e-referral onboarding pause is over. We have new scalable e-referral infrastructure in place to support the full end-to-end referral process. And critically, hospital-based clinics and specialists at several major regional centers are coming on board in 2026 to further fill out the referral network. And the emergence of these standardized referral forms will contribute to making the referral process better for senders and receivers across the network. If you aren't on board yet or interested in learning more or want to share feedback, the website at the bottom of the slide there is a great starting point. And just next slide. Before I turn it over to questions, I just want to highlight that while e-referral is in itself a key tool to support patient care, it is also kind of the groundwork or the plumbing for central intake processes, which are important because they are ways to load balance referrals and improve wait times across the system. And across kind of surveys that are done through the OCFP and OMA, e-referral and central intake are always flagged by primary care as some of the key things that they're hoping the system can do. So we're trying to deliver on that. This work at Ontario Health around central intake is being led by Dr. David Urbach, and initial work is being planned for 2026 onwards. If you go to the next slide, the main focus in this initial kind of tranche of efforts on central intake will be on CT, MRI, orthopedic surgery, and cataract surgery. And these are intended to build on some of the local initiatives that have already risen in certain areas, as well as across regions. And for the final slide, there's always a lot of uncertainty about sometimes how central intake will proceed because it starts to change how we think about making referrals and how referral destinations are selected. But what's really critical is there's been a very thoughtful process here. There's an expert panel that was assembled that brought together clinician experts, academics, as well as health system leaders to really understand some of the key features of the central intake process and how it can be done to meet the needs of patients and caregivers, as well as providers and systems. And what's really important is that, referral routing is intended to be based on things like wait times, destination capacity, geography, but also patient and referring physician preferences. So stay tuned for more details, which will be forthcoming in the next several months. But this is all kind of the work that we're doing at Patients Before Paperwork at Ontario Health. So thanks for your time today and look forward to some questions.
Great. Thanks, Steve, for bringing us up to date on where things are at in terms of e-referral and also giving us a heads up on things that are in the pipeline coming this year, which is exciting to hear about. The first question here actually is just regarding e-referral versus e-fax. So the question is, it's maybe more of a comment. Regarding e-referral, I don't understand what is wrong with e-fax. It's just one button in the EMR and the patient can call the specialist to arrange the date of an appointment. Why create all this complexity? I would appreciate knowing what I'm missing here. Thank you.
Yeah, it's a great question. And I think many of us are familiar with some of this, perceived simplicity, I think, of the initial e-referral process when we use what's existing in our EMR with an e-fax or fax transmission. And I think certainly intuitively, it feels very simple and efficient at the moment of referring. And I think that's why we gravitated towards it as kind of busy providers. I think the challenge is that as soon as we send that e-fax or fax, there's a few downstream challenges that arise. So we know it's not a secure method of communication. It's prone to things like non-transmission, incomplete transmission, or even misdirection. It can contribute to privacy breaches and interruptions in that care transfer of care process. And we know it can lead to delays in care as well. And we know, across the board, most clinics find the referral process fairly onerous and that follow-up to be particularly challenging. So many of us have referral coordinators or dedicated staff that have to follow up on referrals that aren't carried through, that we never hear back from, that just seem to be lost. And so, as I alluded to before, across studies with the OCFP and the OMA, we know that e-referral is kind of one of the asks for many primary care providers, and as well as centralization of intake. So I think there's a broader kind of systems problem here. And so as individual providers, I think sometimes it can be simple to make that, e-fax decision at the moment. But I think as we build this e-referral network, I think things start to evolve that are emergent. As more people join, there's new things we can start doing. So we start thinking also about being able to understand better all the information about receivers, not just locally, but across the province. So having better information around things like wait times, who does what are the options for our patients, what are the best referral destinations. So instead of having our own individual for example, the address books in our EMRs, we can start having a more collated and up-to-date understanding of who is available as a recipient. So that's kind of another advantage that we have baked in here. And I think what happens is this lack of systematization when we're each doing our own thing, that kind of puts a significant burden on patients and caregivers to call and follow up, chase their own referrals. I think it's a very difficult experience for many when they don't have a sense as to what's happening. And it's an extremely frustrating process. I think as patients ourselves or as caregivers, and certainly our experience in clinic, we have an intuitive sense as to what that can feel like when referrals seem delayed or are lost, or it seems like we're, taking two steps back. And I didn't touch as much on this, but also, we've actually commissioned some studies to be done looking at the efficiency of different referral processes, and we're going to have some more data emerging around this. But when we actually do some time studies, when you actually watch how people prepare referrals, a lot of the time we're able to see that e-referral is actually quicker in terms of the number of clicks using the integrated EMRs, as well as in terms of the overall time to initiate and send a referral. And that doesn't account for all the kind of downstream time or costs that happen when we use fax or e-fax transmission. So I think there are a lot of benefits, but I understand that, and this is what I mentioned at the beginning, there is always this tension between, reducing fax, improving the degree of administrative burden, and deploying digital tools, that sometimes there's a little bit of additional work that sometimes might have to be done at the moment of sending a referral. But I think that is well recouped later on. But I know this is a forever challenge for many of us, thinking about, how do I invest sometimes a few seconds to better understand my e-referral platform, or, not do that status quo process of sending the e-fax when I could do an e-referral instead. I think it's challenging for us busy clinicians to sometimes think about how we make that shift on a day-to-day basis. But I think there's a lot of opportunity here, and there's a lot of ways that, as a whole, family physicians, NPs, those making referrals, can really contribute to building a better system that's more kind of cohesive and systematized across the province.
Great, thanks, Steve. I mean, I think you bring up a lot of the challenges that we do face day to day. I mean, full disclosure, I'm probably not the earliest adopter of a lot of things, but I actually am on Ocean e-referral, and I would just speak to the huge benefit of using it over fax. I mean, I love the fact that actually, if your patient has an email, then it will email them about the appointment. You also you get a test back later and you want to send it off, as part of the referral that you already sent. You can then send it as another attachment without sort of resending the whole thing. So, although yes, there's maybe some a little bit of work to get onto the system and just to realize how, understand how it works. But I have to say, I find it relatively efficient in terms of utilization just personally, and I can understand how from a system-wide perspective it's probably very helpful. So another question, actually, this is do e-referrals go to a specific specialist or to a central group? And this person has mentioned that if it was just for individual specialists, then they'll probably keep doing it by hand and fax. I think currently you can choose they mostly do just go to a specific specialist rather than central, except for perhaps hospitals, but perhaps you can clarify.
Yeah, great question. So there's kind of a gradation of different types of ways that receivers can set themselves up. So sometimes individual specialists, exactly as you mentioned, will just have a single listing. So you say, hey, I want this to go to Dr. Smith. It's going to go to Dr. Smith. But a lot of group practices and what we're encouraging increasingly for hospitals, and I think what actually they are already done previously, sometimes with paper forms and e-fax as well as fax referrals, is we've seen kind of emergence of what we think of single entry kind of clinics. So it's not central intake, but what happens is if you have 10 endocrinologists, you can tick, hey, I want to be seen by the next available, or you can still designate a specific endocrinologist, or perhaps you just tick the indication, I want to see for a thyroid issue. And then they'll select the best kind of provider that can meet those needs. So that is definitely something that we're seeing increasingly on e-referral as well. So you can send to, for example, a hospital's endocrinology practice, and then through the kind of internal triage mechanism, they will assign that referral to the best specialist, again, based on whether you say, hey, it's just next available, or I want a specific specialist, or I want someone with this expertise. As we move towards central intake, the intention there is that there's going to be broader oversight in terms of what's available in the system and kind of a more rigorous matching process. And this is, I think, particularly helpful for a couple of the types of referral streams that I mentioned, things like DI, so diagnostic imaging, so MRI, CT. Often, we're sending parallel referrals, or we're trying to understand which is the quickest, which is going to meet their needs, which has the appropriate equipment, protocols, things like that. And so I think what's really critical there is that kind of removes some of that need for decision making on the referrer's part. We can just say, hey, I want this MRI to happen as quick as possible. I want it to arrive at a site that's reasonable for the patient and makes sense for them and meets the clinical needs. So I'm going to send that off to central intake. So I think there's a lot of advantages there. And I think for many of us, that kind of reduces that cognitive load as well as that burden of thinking about, oh, do I send it to this hospital, or should I try a slightly different, area that's 2 hours away, but the patient's willing to travel, it might be quicker. I'm not sure what to do. So the idea with better information and some centralization of the intake that we can better match patients to where they need to be.
Great, thanks very much. And I think you actually answered the next question, which is what if you want a particular specialist and not the first? And most of the time you can just choose which specialist you want or just next available. Somebody wanted to just clarify the difference between e-referral and e-consult.
Yeah, so similar but slightly different. So e-referral is generally when we're sending a request for an in-person consultation. So generally, that's what we generally think of when we're sending out e-referrals. And so e-referral kind of replicates that process. So I'm sending it to an endocrinologist with the assumption that the endocrinologist is going to triage that request and see the patient in person. Or potentially virtually, but usually in person. What's different with e-consult is generally a more contained request, often to review elements of the chart or key information, and it's usually geared around a specific clinical question with the intention that perhaps the primary care provider can get some advice or some ideas about diagnosis, next steps, and treatment to help manage the patient in their practice without the patient having to wait to see a specialist. Or have to go for an in-person or a virtual appointment. And so the intention there is that it can certainly make things quicker for the patient. It can get an answer to the provider, and it can support some of that continuity of care in our practice. There can be some fluidity, though, here between e-consult and e-referral. And we're looking at several pilots. There's been some interesting pioneering work by the e-consult team looking at how we might be able to convert from e-consult to e-referral and back and forth. And I think intuitively that's very interesting for many of us because, for example, it might be useful for some referrals that I send out where the specialist can actually say, you know what, actually you could manage this pretty easily. Here's some quick things to do to help the patient with these symptoms. And what's important about that is it gets the information back quickly rather than maybe a several month wait. and it can actually free up that specialist time for other more critical cases. And so it actually can increase some capacity in the system and reduce overall wait time. So great question about the differences between e-consult and e-referral, but increasingly we're looking at how they can be kind of merged and how there might be some ways to flip from one to the other. I'd also mention that there can be the opposite as well, right? Where someone might request an e-consult and a specialist could actually say, hey, you know what, actually this might make sense to see them in person because we have some key things to do on a physical exam or some other testing that might be appropriate in our clinic. So I think this type of systematization helps open up some new avenues to think about how we can really best meet clinical needs for our patients.
Great. Thanks for clarifying that, Steve. A question just around the e-referral. So is this and I just don't know the answer to this in terms of e-referral, is this the same thing as is available via the OTN portal, or is this different?
So yeah, usually what's available through the OTM hub that most primary care providers are using right now is e-consult. So that's where, again, you're asking a specific question of a specialist regarding a specific patient case. And so that is separate. Now, right now on Ocean, which is again the referral management system, for e-referral, you can access e-consult. So you can actually use the same flow to access e-consult. So, and it's directly integrated with your EMR, which is if you're using Oscar, PSS, and Accuro. And what's great about that is all the patient information flows. I think for many of us, the OTN hub can be a little challenging because you have to manually enter a lot of details, transfer attachments or other documents. And if you use the Ocean e-referral workflow, that actually gives you direct access to the OTN e-consult platform. And so that's a kind of nice way to kind of merge the two, but they are kind of distinct. But again, there's kind of this intention to kind of bring them under the same umbrella and kind of improve some of those workflows.
Great. Thanks very much, Steve. And yeah, I would echo, I love the fact that you can access your consults through Ocean. It makes it much simpler. You don't have to go into a whole second system and go through that whole process. A question regarding my EMR auto-populates my referrals. Does it do this for forms for e-referral?
Yeah, so again, with those integrations with the main EMRs, the intention and how it works right now, which is great, is when you kind of launch a referral out of your EMR, key information flows across automatically. So the key things would be, patient demographic information as well as your provider information. And then there's the opportunity to also share specific documents, lab results, and other things directly from your EMR as attachments into that e-referral. And so I think that's such a critical piece of this work, because without that, it's a very kind of challenging, clunky process. And so what's important there is that it's meant to replicate many of the ways that you already create a referral, but that information flows seamlessly. And that's important from a user experience perspective, but also from a security perspective. It's never great to be downloading information and then retaining that on devices. So a lot of ways that's kind of baked into the process here. And again, what we're kind of building on the other end is for receiving systems. So I mentioned the hospitals. The intention there is that a lot of the information also directly flows from this digital process into their HIS. And so again, reduces need for administrative burden for manually transferring the information, as well as reduces issues around manual rekeying or errors that might happen in that transfer process. So it's a really key feature that we're able to do that transfer of information directly from your EMR into the e-referral platform.
Thanks, Steve. A question regarding attachments. So someone's written here, I love Ocean, but the major concern for me is attaching results to referrals. This person is having to save the document outside the EMR before attaching it to Ocean. Could you comment on the attachment process?
Yeah, so it might depend exactly on which EMR. We know there have been occasionally some hiccups with certain EMRs, but generally for most deeply integrated EMRs, so I mentioned several of them. So PSS, Accuro, Oscar, and another one's Avaros, and there are a few others that are coming up. That that attachment process should be seamless. If you're having issues, you can reach out. But I know Akiro is one that sometimes has some issues. I think there's going to be improvements in that process, but I know that's been something that's been flagged to us as a group, and is something that's been flagged to both Ocean and Akiro before. So, watch for some improvements there. But I know that's been a little bit of a challenge for sure. But I think for the most part, the integrations otherwise are pretty strong and have been, I think, a big win in terms of a product that works pretty seamlessly with the flows that we're hoping for in primary care.
Great. Well, I mean, it is good to hear that that's something that's been recognized for the Akiro platform, because I wonder if that is specific to that question. So good to hear that it's something that's going to be worked on and hopefully sorted out to make everybody's lives easier that's using that. A question regarding e-referral. Will it include areas of interest, example, general surgeon, breast, hernia, colon, ortho, spine, knee, foot, shoulder? I guess talking about the central intake idea, how that might flow in terms of areas of interest.
Yeah, so in terms of central intake, yeah, so the intention now is to have some kind of key kind of verticals. So there's going to be, as I mentioned, the CT, MRI, and the next kind of tranche is going to focus on things like knees and hips, as well as cataract. So it will probably be fairly narrow initially. There is interest in, kind of broader, for example, e-referral, or sorry, central intake to a broader specialty type. Part of this is actually less technical work, and a lot of it focuses on how do we think about, assembling groups of specialists to agree on kind of the central intake process for a locality or a region. So I think there'll be some emergence that will look a little bit different across regions. But certainly, if there's strong interest, either from referrers or from specialists in terms of how they want to think about setting up central intake, I think there's a lot of opportunities as well as appetite to think how we can kind of best support that. But I think, again, the initial central intake that's being planned right now will be fairly narrow, specific indications, like I mentioned, around diagnostic imaging, as well as some initial surgical procedures.
Thanks, Steve. I'm just looking cognizant of the time, so I'm just going to flip to finish our last few slides, and then we will come back. There's still some questions in the chat that in the Q&A that I'd like to ask you, but we'll just bring the slides up for a moment and finish things off for those people that have a strict 9 o'clock deadline. And I'll turn things over to Jobin.
Thanks so much. So just a quick heads up that today we also have a session on antimicrobial stewardship in primary care audit and feedback to improve antibiotic prescribing. This session will be virtual today from 12 to 1. If you're able to join us, please join us, and I'll be hosting that session. Next slide, sorry. And then a reminder of our many communities of practice, including Practicing Well, and our health equity community of practice. The slides, the dates are on the slide here. And also remember about our Peer Connect mentorship. If you are interested in becoming a peer leader, we'd welcome you. Next slide. Handing it back to you, Eleanor.
Great. Yeah, and this is just a reminder that if you're in your first 5 years of practice, we do have a community of practice for you. Our next session is next Tuesday at 7 o'clock. Work smarter, not harder, managing your inbox and paperwork. And I know that session is being given by Dr. Dan Pepe. So if you're in that first 5 years, certainly please do register. We'd love to see you. Next slide, please. And just a reminder, if you missed some of our previous sessions, they're all available online. Feel free to grab them. The slides are also always there, as well as the video presentations. Next slide, please. And our upcoming session, our next one will be on February 6th. So look forward to seeing those of you there. With that, I think that's the end of the slides. Correct me if I'm wrong. Just a reminder that session slides today will be available usually by the end of the day. And please do remember to fill out our evaluation form. We do really appreciate your feedback. We take your topic suggestions, your process suggestions to heart. So please, just a reminder to fill out that form. It really helps us out. Next slide, please. Okay, I think that is the last slide. Yes, so let's turn things back and maybe, put Steve back on the hot seat here. So just a question regarding when a referral is sent, is it reviewed before it's accepted? And if it's reviewed, is it reviewed by a specialist or a non-medical clerk? And I guess this might depend on where it was being sent, but perhaps you can answer broadly speaking.
Yeah, so it depends. I think we're talking about maybe both e-referral and central intake here. In terms of e-referral, the intention there is that it would follow the same kind of review and triage processes that probably already exist. Obviously, when sometimes a group comes on e-referral, though, they might kind of review how they're thinking about the triage process and who's looking at referrals. But in general, that process will probably replicate what already exists. So that might be reviewed by administrative staff for completeness. Sometimes it might involve like an NP, a PA, or someone else on the team who looks at the referral and decides if it's appropriate or meets kind of scope of practice. And then it might also be triaged initially or later on by the specialist. So there's some different processes, but we're not necessarily dictating how that would happen on the specialist end. So that's still kind of the specialist kind of decides how that works. With central intake, the intention isn't necessary to make kind of clinical decisions at that kind of central hub level. What's critical there is making sure information is complete, that the kind of flow of information has gone to the right spot. So the hub, the way they're going to work is there's also opportunities for them to be rerouted. So if it's not going to the right track, there's ways for it to, for example, be sent to a different track or rerouted in a different way. So I think you'll probably see that as this kind of emerges, a lot of the triage will feel kind of similar to what's already happening, as well as that kind of initial review. But this is something that we're going to explore, and I think we want to, work carefully with system partners as well as clinicians to ensure it's really meeting our needs. Because again, this is intended to be a key thing to simplify referral processes and not make things more frustrating. So I think we're going to have to listen very carefully to the experiences of many of the existing, central intakes that have grown up in many localities across the province. There's tons of expertise out there already as to how to do this really well. And so I think we're going to kind of build on those experiences going forward.
Thanks, Steve. And a question from Ian here. Is e-referral just another digital barrier? There's no real-time response to it. So just your thoughts and comments regarding its usage.
And sorry, I missed the second part of the question there.
Yeah, I think just that there is no real-time response. I guess you don't get an immediate response when you send something off. Is it creating another digital barrier that we're having to go through to get these referrals off?
Yeah, I think what I think about when I'm sending e-referrals is that it gives me some kind of confidence that things are trackable and something's going to happen on the other end. We know that there's kind of broader professional guidelines that specialists should be responding within 2 weeks of receipt of referral. We know that definitely doesn't happen a lot of the times, and we know certainly with fax-based or e-fax-based referrals, there's major gaps in terms of that communication back. And I think that vacuum in communication is very challenging. And so what I usually think about is, again, the benefits really to me as a provider is that I have confidence that this is going to end up somewhere and someone's going to address this. And if not, there's kind of traceable ways that I can kind of ensure that I'm not losing track of that and that the patient is also aware of the progress. So while it is another digital tool, I think we're trying to make it as seamless as possible, but also make sure that it's something that actually responds to our needs. And I think, again, for many of us in primary care, lots of frustration when referrals aren't kind of completed, when they're not responded to, when there's uncertainty in that process, when patients are calling in or asking questions about their referral status. So I think we're really trying to reduce all that noise. And even if, it is a new digital tool, I think the intention is that it kind of removes some of those other major challenges that we see day to day in our practice.
Great, thanks, Steve. And this is a question, actually, it was posted in the chat, and I don't like to encourage questions in the chat, but it came up a few times, which was regarding the email notifications that come back after you've sent an e-referral and how those can be a little bit cumbersome to deal with. Wonder if you could comment around that.
Yeah, and I assume this is from feedback from patients, caregivers. I think we're continuing to look at those and see ways that they can be improved. I think one of the challenges is that Ocean has its own system. Also downstream, a lot of institutions as well as receiving clinics also have their own ways to kind of send updates around the status of the referral. So we're looking at ways to kind of streamline that process overall and ensure that it makes sense for patients and caregivers as well. But I think in general, it's seen as a positive step to even just get that first kind of recognition that a referral has been placed, even information about who the recipient specialist is, and some initial ideas about how to follow up if there's any questions. So I think, again, something we're continuing to work on. I think it's a great point that, in this whole process, even though we talk about, these kind of being monolithic solutions, we're still really looking at ways to continue to improve things. So if there's specific feedback or you've heard things from patients or caregivers in terms of, email functionality, or if you have specific suggestions, we're all very open to this. There's routes to provide that feedback either through the website I mentioned. There's ways to do that directly through Ocean. And then certainly you can reach out to us directly as well, because we are collating this feedback, and we have kind of a roadmap for ongoing review of requests, feedback, and how these can translate into important enhancements that make the system better. So we love feedback, and I think a lot of this program has been predicated on understanding that we need to continue to evolve, and not everything will be exactly right from the get-go, but I think we can keep moving in the right direction, and hopefully it'll make things better for everyone going forward.
Thanks, Steve. And actually, there was a question regarding feedback. And so maybe just to ensure that I've understood correctly. So the question that the person sent in was, if we see a problem with a current small clinic e-referral form, for example, the CPP is not populating, do we share that feedback with the specialist clinic or do we contact Ocean?
Yeah, so you can reach out to the specialist clinic. I would probably say work through Ocean, and each region also has what are called deployment teams. So there's information on the website as to how to contact them. So they're responsible for different regions across the province, and they're very well versed and understand Ocean integration as well as the overall e-referral process. So if there's a problem with a form, they're probably the best to troubleshoot. But certainly if there's other problems, I'd also say there's also opportunities for feedback in some of the other specific elements. So for example, the standardized referral forms, as they're rolling out, there's opportunities to provide direct feedback about the specific form. And so there's a lot of ways that if you see something that doesn't seem right, take a moment, let us know, and hopefully it's something we can address quickly. Because again, what you do, one of the advantages here is with this kind of broader system of a referral process is that if you make a change or improve things, that populates to everyone. And so instead of everyone having to kind of troubleshoot their individual referral processes, the problems you see can be solved for everyone across our network. So I think that's a big win. So if you have the moment to invest that time and share feedback, that's amazing.
Great. Question, is e-referral available in long-term care on PPC? I hope you know what PPC means, because if not, we'll have to ask this person to pose the question again.
I'm guessing it might be PCC, point click care. I'm guessing.
Okay.
So it's not directly integrated, but even if you're not using an integrated EMR, there are plans for several other EMRs to have deeper integration in the coming short while. Also, e-referral can be available through a portal. So even though it doesn't offer that same transfer of information as some of the deeply integrated system, if you are sending occasional referrals from LTC and you're using like point click care, there's still ways you can use e-referral and get some of the benefits of trackable referrals, ensuring there's updates, being able to communicate with the specialist, as well as ensuring it's kind of that secure digitized process. So certainly something you can still use as a kind of standalone portal, but I think we're hoping that some of these other major systems will have deeper integration in the next short while.
Great. And a question regarding how are urgent referrals dealt with separately from non-urgent referrals? I think probably, again, this might depend on the specific referral.
Yeah, I'd agree with that for sure. So generally, central intake is not intended for urgent referrals. So I just preface that. And then other referrals that are, very urgent, it depends on kind of, the degree of urgency as well as what that recipient might look like. I would still say, as you might be doing with any referral, if something is urgent, you might still have to work in addition in parallel with e-referral to ensure that the recipient has received it and they're acting on it in a timely fashion. So it might mean picking up the phone, sending an email. But I think increasingly as clinics are more comfortable with e-referral, receiving clinics will very much be understanding that referrals coming into their inbox need to be triaged quite frequently and regularly. And so hopefully there's a sense that, urgent referrals would still be picked up in a timely way and addressed. But this is something that, we currently see across the board in terms of challenges sometimes with urgent referrals being addressed and triaged appropriately. And so I think there's still a need to kind of replicate some of those processes where we do some close follow-up. And it might be something else that you just need to flag. For example, myself, I'll set a quick reminder, for a day or two if something hasn't been addressed, and might task my staff to follow up quickly if I'm not sure if it has been fully triaged by the receiving site. But I think there's still some value in having that fast follow-on. But I think, again, there will be an understanding from receiving sites that being aware of what's in their referral inbox will be really critical in terms of ensuring things are triaged in a timely way.
Great. Thanks very much, Steve. There was a question about registering for e-referral, so I'll just remind people that there was a slide that introduced how to sign up if you haven't already signed up for it. You have to sign up for Ocean, and I think it's fully outlined in the slide and the link that was in your presentation, correct, Steve?
Yeah, for sure. That link at the bottom should guide you through that process. And there will be some ways to do some kind of express self onboarding in short order, which should really facilitate the process. So a couple of documents to sign, a little bit of back and forth, and a lot of that's just around ensuring that kind of the data privacy agreements are all in place because we are transferring PHI through the system. So that's the main thing around the onboarding, and then as well as depending on the complexity of your clinic and if you're a receiving or sending site, there's many ways that the deployment teams can also support to help you come on board. So all should be available via that website.
Great. And then a question regarding when you are doing a referral, maybe if people haven't used the system before, they're asking like, are you able to refer to specific doctors, or do you start with the specialty in the search bar? And I think you can do it either way, but interested in your thoughts, Steve.
Yeah, and if you're curious, you can go right now to Ocean Health Map. You don't have to sign up, so it's oceanhealthmap.ca, and you can play around to see what it looks like. And so you can look at, based on a certain postal code, you can search by specialty, you can search by doctor name, you can search by indication. I will say what we're trying to do, though, and again, this emerges from what had happened over the last several years, is that there's a little inconsistency in terms of directory listings. So people list things and describe things in different ways. We are looking towards having a more systematized way of describing scope of practice, eligibility, and having names and other indications searchable. But I think you can often find what you're kind of looking for based on searching for, as you mentioned, name of a provider, the specialty type, or the indication. And then there are pretty fulsome descriptions in terms of what clinics tend to offer. I will say there are some wait times as well in the Ocean Health Map. A lot of those are derived by sometimes self-report, as well as some calculated wait times. But again, part of our roadmap is we're expecting much more rigorous wait times to emerge as we get kind of that central data on what referrals are looking like as they flow through the system. So feel free to play around, take a look, and see what it looks like for your kind of local region.
Yeah, I would just add that sometimes, I don't know if other people have this experience, but I have patients that don't live in this community anymore, and I'm still caring for them. And it can be very helpful to find like local specialists and stuff, even if they're not even currently on e-referral, at least lets you know who lives or who's working around where that person lives, because I think it does search geographically close to the patient's home. So that's just like an added benefit, and hopefully as more specialists come on board, I'll also be able to refer to them that way as well. And then I think we'll just finish with one last question. And is there any kind of backline telephone number provided where you can speak to someone to ensure a referral is being acted upon? And I think this is probably also dependent on the referral, but I do notice usually when you put a referral in on a form, there aren't any phone numbers provided. I guess that's that the organization chooses not to provide them. Anyway, thoughts on that?
Yeah, and unfortunately, as I mentioned, it's still that kind of same process. So again, most of them will have in a clinic listing some other information, and so it will be kind of that same type of follow-up that you'll have. Again, what we're hoping though, as clinics are more using this kind of in an increasingly rigorous way, that there's an understanding both about that, 14-day turnaround time that's kind of required by professionalism guidelines, but also that there's kind of an expectation in terms of how referrals are acted on and responded to. So I think we'll see that increasingly emerge. But again, if there is a referral that you're especially concerned about or something that seems very urgent, I'd suggest that people continue to use kind of their existing backline channels, which often involves, phone, voicemail, email, reaching out to someone at the clinic. And I think that'll always kind of exist in certain ways. I think that's what we do sometimes, for patients that have specific needs or very timely requests that we make, and that we often have to talk to someone or make sure that it's seen or heard in an appropriate time frame. So, I think about that when I send people sometimes to the hospital or things like that as well. And so I think it's similar processes around that. But I think certainly that's always top of mind for providers. So, something that we'll continue to work on and monitor and think about how we can improve that process to ensure that even those urgent referrals are handled in a very timely way.
Great. Well, thanks very much, Steve. And I thank you for answering all these questions. Also wanted to thank Alon again and Dan for joining us earlier to talk about infectious disease. It's 9:15. I hope everybody has a wonderful weekend. If you're in Toronto, good luck digging your car out of the snow, and look forward to seeing you guys in February. Thanks again, everybody. Take care.